Good morning, everyone, and welcome to the second annual Within Summit. My name is Ashley Barkoviak, and I'm the Clinical Operations Coordinator here at Within Health. Today, I want to introduce you to Emma and Chrissy. Emma received her Master's of Science in Clinical Mental Health Counseling from the University of North Carolina at Greensboro. In addition to having experience working with individuals seeking treatment for eating disorders at all levels of care, Emma is a National Certified Counselor through the Board of National Certified Counselors and has training in evidence-based approaches such as cognitive processing therapy. Passionate about helping clients heal from trauma underlying their eating disorders, Emma often utilizes the expressive arts in her work with clients to help them process and creatively express their lived experiences. I'd also like to introduce you to Chrissy. Chrissy is a registered nurse here at Within who has been working in the field of eating disorders for the past 10 years. She has a passion for helping clients fight against their eating disorder voice so they can find true and lasting recovery. In addition to caring for clients directly, Chrissy also spearheads the compliance efforts of Within Health, including state licensing and Joint Commission accreditation. Emma and Chrissy will be presenting on Opposites Attract, Therapy and Nursing as the Complementary Forces in Eating Disorder Treatments. Before we kick things off, I do have some information to go over in regards to the CEU credits. Evaluations will be sent to your email that you use for registration for this presentation. Once the evaluation is complete, you will receive a link to download your CE certificate. Please utilize your CEGO dashboard for all things CE related. A video of the presentation will also be available after watching this video. You, however, will not get credit for just watching the video. You must attend live in order to receive the credit. To access the video, please utilize your CEGO dashboard for that as well. If there are any technology issues that come about and you need to change devices during the presentation, you will receive credit for that. For any additional questions, concerns regarding obtaining the credit or any technological issues, like I mentioned, I will provide my email in the chat as well as Jamie Singletary's and CEGO's support methods as well in case you need to get in contact for your CE certificate. I will now pass things over to Chrissy and Emma.
Hi, welcome everyone. We're so excited to be talking with y'all this morning and hopefully just having a back and forth conversation between the two disciplines represented, therapy and nursing, about how we really can work together to improve client outcomes. So if you want, Chrissy, I just realized I will go ahead and go to the next slide, and then Chrissy will talk a little bit about our agenda for today and what we'll be going over. So our objectives for this talk, we want to talk about ways in which the approaches of nurses and therapists can be complementary in the treatment of eating disorders. We'd love for you all to be able to identify a minimum of 3 benefits of greater collaboration between therapists and nurses within eating disorder treatment, and to describe a few strategies for increasing collaboration between therapists and nurses within an eating disorder treatment setting.
So we're going to do that by looking at a multidisciplinary approach to treatment, capitalizing on collaboration. We're going to look at a few specific case studies. We're going to give some practical tips and applications, and then we'll leave a little bit of time at the end for any questions.
Awesome.
So I don't know if anybody has ever heard this, but I've heard it a couple of times. What exactly do you do all day? I like to say, said no professional ever. So we talk all the time about the importance of a multidisciplinary team in eating disorder treatment, but so often we end up operating in our own silos. We refer to each other, but the collaboration isn't always as strong as it could be. And one of the things that we firmly believe is that the collaboration that we can have between disciplines has an immensely positive effect on patient outcomes. So rather than operating in our own silos or in our own parallel highways, one of the things that we want to emphasize is that we can actually come together and work together, maybe in the same highway. So in the following slides, we're going to talk about the multidisciplinary approach to treatment and the role that therapists play and the role that nurses play in these teams. These are, after all, our disciplines. I'm a nurse, as a therapist, so we think they're pretty important. And they're often and they're often seen as opposites. So what we want to focus on today is ways in which these two disciplines can collaborate. we want to point out some of the ways that members of these disciplines can leave their own lane and we can move into that unified highway.
Absolutely. So before we go into kind of the nuts and bolts of how we might collaborate, and a little bit of the background of therapy and nursing, we want to kind of take a big picture, broad view of what multidisciplinary approach in eating disorder treatment looks like. We all know that a multidisciplinary approach really is the gold standard of care, particularly in eating disorder treatments, because we know that eating disorders are biopsycho social illnesses. They affect a person physically, mentally, socially, psychologically, spiritually, every way possible, and it requires a whole team of people. So we wanted to cite a little bit of the literature, found a few interesting qualitative studies that brought in clinicians' sort of experience on how important that multidisciplinary approach really is, particularly in eating disorder treatment. A lot of these studies were looking at higher levels of care, but showed that across all levels of care, having that true diversified approach was incredibly important. A study by Davidson et al. In 2019 was really interesting in taking physicians' perspectives in particular and talking about how doctors at higher levels of care really valued having therapists and nurses and dietitians on the team. And that when those disciplines are able to come together, it helps us see, quote unquote, the big picture of a client's treatment, and helps us really make informed clinical decisions that consider the whole person. We also, a lot of those studies highlighted that that type of multidisciplinary collaborative approach really helps teams decide which discipline is going to take priority and precedence at which times. And what we mean by that is there's not one discipline that trumps the rest, right? We all have an incredibly important part to play. And at times, may even need to, step forward or backward, depending on what the client needs. So if we think of a multidisciplinary team, right, so often we think of all the different disciplines as kind of separate but equal, right? We're all in our own little spot. We all have our own lanes on the highway, right? And it's really easy to kind of compartmentalize or to think of us as separate in our own silos. But coming together for the betterment of the client. What we would like to think of, though, we'd like to challenge that notion a little bit and add a little bit more nuance and recognize that there's actually so much overlap between what the different disciplines do. And there's no one discipline that takes precedence at all times, right? Like we showed here, sometimes there's movement and stepping forward and stepping back in such a way that different disciplines may take the driver's seat and others may take a more supportive role. And this all depends on the individual client's needs and goals. So again, this is where coming together as a team with a unified vision of what a client needs and having a unified case conceptualization and treatment trajectory can really help us capitalize on each of the different disciplines and how we can work together, like Chrissy said, on a unified highway rather than our own little silos. Oops. Here we go. So when we think of therapists and nurses, there's quite a few ideas out there, some of which I thought about including the traditional graphic of like the therapist on the couch, that Freudian stereotype. But really, when we think about therapists, even in our day and age now, we often do think of the therapist and the client sitting on their chairs or their couches, talking about feelings, and therapists hopefully fixing their clients, right? And that's a great idea in an idealist world, and that's not the way therapists are trained to work, and it's not the way the real world works. In fact, our training as therapists or as counselors, whatever that discipline might be, is to actually take a client-led approach. take an approach that doesn't come in as an expert telling the client, this is what you need, I'm here to fix you, but to rather help the client come to their own solutions, to find their own path, to tap into their own sources of healing and to their own support systems in their life. This is especially important in eating disorder treatment. So rather than sit on a couch and talk to people all day, what therapists actually do all day is provide that individual therapy to individual clients, couples therapy, family therapy, group therapy, really guiding clients and coming to their own solutions and feeling empowered. And the way that we do that too is by really diving into the process of what's happening in the room in the present moment, and to really help clients understand what's happening inside of them, inside of their bodies, inside of their minds. We provide a lot of education on eating disorders to clients and their families. Of course, imparting coping skills, which is especially important in the earlier phases of treatment when there's a lot more distress. We're also exploring roots of the eating disorder, particularly any traumas that might be there. And then something else that sometimes we might forget about, not as therapists, because this is at the top of our minds very frequently, but it might be easy for others to forget that therapists are also focusing on a client's safety. They're looking at suicidal ideation, self-harm, substance use, anything that could affect a client's safety, and really trying to plan with a client to empower them to take their safety into their own hands. Something else that we do that is a little more behind the scenes is coordinating with outpatient providers. If they have an outpatient team and they're at a higher level of care, if they're an adolescent or college student, we're coordinating with schools and any other entities that would help support a client in their treatment. So a lot more than just talking about feelings.
Thanks, Emma. One of the things that you said struck a chord in me, and people have spent some time with me know that I really don't like the word just, because I think that it minimizes so much. And so when we talk about nurses on the flip side of the therapist and what do we think nurses do all day, I think that there are a lot of assumptions. When I worked in a hospital, I was asked things like, so what, you just give people their medicine all day? That word just is, I don't like it. In the eating disorder world, I was asked, so what, you just flush toilets all day? Most people that work alongside us know that's not quite it, but I think that there are some assumptions about what our day looks like. They think it's filled with passing meds, flushing toilets, passing more meds, eat with a client, flush more toilets, pass more meds, do some vitals, chart. One of the things that I think can happen is that a nurse is typically around for the majority of the day. And so we can be seen as a warm body or just a nurse who can fill in the gap wherever we're needed because we're always around. And while we do actually do all of those things that were mentioned, there's also a lot more that we do. We educate. So when it comes to medications, we're not just passing the medications, we're talking about their uses, their side effects, their mechanisms of action. And a huge piece of eating disorder treatment, whether or not they're going to cause weight gain. Talking about labs and diagnostic results. We discuss these with the client so they have a better understanding of what's going on in their body. There are a lot of times that medical providers are busy. They may explain things in very medical terms, and then the patient might be so overwhelmed that they don't have any questions in that moment. And then they come to us and they have all of the questions for follow-up. And so we can do a lot of that education. We educate families. So we have a huge amount of communication with families. Families can be the number one ally and often inadvertently the number one preventer of recovery for a patient. So we can provide a lot of education to families so they understand the gravity of the situation. We can coach families on how to best talk to their loved ones about their eating disorder. We do a lot of that. We can join clients for meals and snacks, in more than a warm body type of situation. We're talking to these clients every single day, day in and day out. We know what they're struggling with. We can be a primary resource and support for them. So when there is a need for a snack challenge to happen, I want to challenge other disciplines to call on the nurse and see if they can be involved, see if they can have that snack with them. It can be such a powerful experience to draw in the nurse as another member that can really be that significant support to a client. And one of the major things that we do is we help to link what a client is feeling to how it might be caused by their eating disorder. So we can take hypoglycemia as an example. You're feeling anxious and have a headache 30 minutes after you eat. Maybe you have hypoglycemia. You're tired all the time and you feel like it's getting worse right now. Fatigue is a huge piece of eating disorders. One of the things that I often like to point out to a patient is maybe it's actually getting better. You were so fatigued before and it was such a normal part of your life that you didn't even know that it was happening. And now that you're actually a little bit more nourished, maybe it's getting better. And when it comes back, it feels really, really bad. That's actually a good thing. Constipation, one of our favorites to talk about. Are you hydrating enough? Are you eating enough? Do you have some gastroparesis going on? So we can provide a lot of that education to our clients. We can go on, I think, to the next one, Emma. So early on in my career as a nurse in the eating disorder field, I felt confident talking about everything that I just shared with you. But I was really afraid to be seen as stepping out of my lane. My training as a nurse was very practical and took a very direct approach. You're feeling this way? Let's do this to see if you feel better. Therapy doesn't work like that. Emma, how does therapy work?
Yeah, therapy, as we're trying to highlight here on this Venn diagram, takes a much more explorative, you could sort of think of it as a process-focused approach. We're not going to come right out and say, well, I think this is what you should do. Most of the time, we're going to help the clients come up with their own solutions that fit with their lives and their values. Not only does this tend to work better for clients, but it also is more long lasting, right? We get their buy-in that way. But as a result, it takes a lot longer, right? There's a reason why within health, we don't have 1 or 2 therapy sessions a week in PHP. For our PHP clients, they have 3 therapy sessions because it does take longer to kind of dive in and get the client to that place because of that process-focused approach.
But one of the things that we have also discovered, and this is where this slide comes in, is that it really is kind of like a Venn diagram. So we have a nursing approach, we have a therapeutic approach, and there's actually so much overlap in the middle. And I think one of the things that Emma and I have both learned through the years is that there's so much power when we can talk about things that are outside of our lane. It reinforces from every single angle the healing that we're wanting somebody to achieve. So while, yes, we come from different schools of training, we all have that approach of compassion. We all have that approach to be client-centered and client-focused. Emma can talk about vitals with somebody, and she can do that from a therapeutic lens. Kind of like I can talk about somebody's therapeutic struggles, and maybe I'm not processing that in a way that a therapist would, but I can validate them. I can know what their therapist has been talking to them about in terms of coping skills, grounding tools that they need, and I can help to reinforce those when I'm meeting with them. At the end of the day, what we know is that we all deeply care about the well-being of our clients. We deeply care about their recovery. And when that is coming first, we can step out of our lanes to support each other in our different disciplines to help those clients move forward.
Right. And I think for therapists in particular, I know early on in my career, I was terrified to step out of my lane, right? And the work environments where I trained, and that was actually a big phrase that was used, stay in your lane, right? And to an extent, that's important, right? We've got to have ethical boundaries. We need boundaries to stay within our training and our expertise and what our licenses allow us to do. And like what Chrissy's talking about, there's so much more overlap than there are differences, at least in our perspective, right? And that's what we realized when coming up with this. We were like, wow, this list in the middle, this overlap piece, we could keep going. There's so many more things that we have in common than we do different. And at the same time, the differences are important to recognize. And so again, it's finding that unified trajectory where maybe instead of having a bunch of parallel roads, we can come into a unified highway. And sometimes it's okay to, to switch lanes a little. Yeah. There you go. That's the phrase. Yeah.
Just swerve just a little bit. So, we have our distinct roles, and those are important, like Emma said. And one of the things that we can do within those roles is we can really capitalize on collaborating with each other instead of always punting things to each other. So how do we actually get those pieces of disciplines to meld beautifully with each other? So we can start by looking at medically compromised clients. And I know that we have a wide range of people who are here with us today. We might have people who work in a residential setting. And I'm sure in a residential setting, you've heard somebody say, oh, this person needs inpatient. We have a lot of people who work in the PHP and IOP levels of care. And I'm sure you or someone that you work with has said, I think that they need PHP or res or the hospital. And if you work in an outpatient setting, I'm sure that you have seen people that you've said that person really needs IOP or PHP or res or the hospital. And for whatever reason, they're not going and you're taking care of them. And we have these medically compromised clients coming into our care. And when they do, collaboration is going to be key. So in those cases, you want to bring nurses in right away so they can help to navigate those complexities. And if you're in an outpatient setting, maybe it's collaboration with the medical provider. Maybe there's a nurse in that PCP's office that can be your ally to really help you with some of this. And it can be super important because when someone has a lot of medical complexities going on, those topics and concerns often hijack some of those therapeutic sessions. So this might be an opportunity where you do bring in that nurse as an ally for you to answer some of those questions. This may be an opportunity to, though we try to avoid this all the time, punt that to the nurse and say, I want you to talk to your nurse about that because in our sessions, we're going to be focusing on your trauma. We're going to be focusing on these other therapeutic pieces. Mm. But it can also be an opportunity where maybe you join together. So if we used bone density as an example, somebody gets a bone density result that maybe is not favorable. And this can be really, really hard for somebody to hear. Some of the best interventions that I've seen with this have been where a nurse and a therapist together do a session. So they come together. They don't have to be siloed. They don't have to be separate. It doesn't have to happen at two separate times. Both of you are in the same room together, and you're going to have that conversation with that client from a therapeutic perspective, from a medical perspective. I know I have learned so much from hearing how a therapist talks about it with a client that I feel comfortable using a lot of that language now. And I know that some of the therapists that I've done this with have also learned a lot of what I've said and feel comfortable talking to their clients about it also. So one of the other pieces that I want to say to those non-medical people who are here this morning is find those nurses that are your allies and learn from them. Talk to each other. Learn from each other. Get to know what happens in that other discipline so that you can be supportive of everything that's happening in someone's treatment for that best possible outcome.
Mm-hmm. Even if that communication happens outside of sessions, I know in the outpatient setting, we don't always have the luxury of being able to have those joint sessions as easily. But having that high level of communication outside of sessions, where for me as a therapist, knowing exactly what a nurse is talking about with clients, what their recommendations are, what the client is struggling with, like for instance, struggling to hydrate, that gives me information to then reinforce in my session. So we don't always have to have those firm boundaries where we're separate. Sometimes we're actually reinforcing what the other one is saying, and really trying to back each other up. But to do that, we need a lot of communication, not just in team meetings. Oh, one last thing that I was thinking, Chrissy, while you were talking too, I was like, yes, and this can actually work for psychiatrically complex cases as well, but especially for our medically compromised clients. As a therapist, it's been so helpful for me to have a client who, when they bring medical concerns up, to ask their permission, hey, this is important, and I would love to have your permission to go ahead and send a message to your nurse, because I want you to be able to address this at your next checkup. And I want them to have a heads up that this is going on for you. 99.9% of the time, the client is like, yes, that would be helpful, because, I might forget, or it's really hard for me to bring up to the nurse. Or I'm embarrassed talking about this in general, right? And so don't be afraid to get creative in the ways that you communicate. But in talking about psychiatrically complex cases, we don't need to cite the literature. I think it's pretty well known, and even just from Dr. Moss's talk yesterday, that there's a lot of co-occurring disorders that come along with eating disorders. And so we get a lot of clients who have co-occurring, not just medical diagnoses, but psychiatric diagnoses. And it can be a true interplay of these. We have to treat the whole person. We have to treat all of these things at once. And so this is where nurses and therapists are so vital to have as active forces on the treatment team, particularly when it comes to medications. We want to highlight the powerful role that nurses and therapists can play in helping clients, maybe who are scared to take medications, or who have, they've received negative messages in the past. They might have eating disorder-based fears, like fear of weight gain. Help them begin to consider medications that might benefit them, medications that their psychiatric provider might be recommending. The beauty of therapists and nurses in this situation is neither of us prescribe, right? So we get to kind of come at it from not a totally objective standpoint, because we care about our clients deeply, but kind of as an outsider, and be like, hey, your psychiatric provider is recommending this, and you have some concerns. Let's talk about that. And the really cool thing about therapists and nurses asking that question is that conversation is going to look totally different for a nurse and for a therapist, right? This is where the opposite approaches of therapists and nurses are so complementary. Chrissy might be talking about, the actual biomechanics of how medication might work, and giving some medication education, talking about side effects, talking about how to best take it, all of those sorts of things. Whereas me as a therapist on the flip side might be talking about the beliefs, right? What are the things that are preventing you from considering this medication? What are the fears that you have? What are the familial and societal messages that you've received? What are the practical barriers that are getting in the way? Actually, something too that we thought of is that nurses are also fantastic at really helping tackle practical barriers or pragmatic barriers. What we mean about that is, the things that are actually getting in the way of the client attaining the prescription, refilling it on time, taking it at the times that they need to. Nurses can really come in as a fantastic support to help clients essentially remove those barriers and get the care and the supports that they need, especially when it comes to medication. So again, medication adherence, follow through on medical recommendations, nursing and therapist collaboration we believe can also really help when it comes to maybe more psychiatrically complex cases where there's a trauma history, something where there's a high potential for client splitting, right? Where a client presents one way and says one thing to one provider and says another thing to another. So when we have this collaboration between therapists and nurses, it really helps prevent that potential, right? Because me as a therapist, I know exactly what nursing is recommending and exactly what they're sharing, and vice versa. And we can really make sure that we present as a unified front. And maybe, like Chrissy said, even have some joint sessions, which could further prevent that potential for splitting. So we can move on to family and team settings. So with family and team settings, this is again where we believe that complementary approaches of nurses and therapists can work together beautifully. Really, I think too, before we dive into that though, I want to acknowledge that often we don't consider nurses in family settings, right? When we think of family settings, we think of family therapy, right? And that's something that a trained licensed therapist can and should provide. And I'm going to pass it over to Chrissy a little bit. We want to talk a little bit about how we can utilize nurses in the family setting and use their approach and their skill set in a creative way.
Yeah. So one of the things that we as nurses, and I love to say this, is I'm not a therapist. So when I approach a family, sometimes they have a fear of therapy. They have had a poor experience with it. And I get to say, well, great, that's not me. I'm not a therapist. And so again, coming from that role of being trained in very practical things, one of the things that we do in coaching is we can give very practical tools to family members and how they can best approach their loved one who is suffering. Nobody, I'm sure it happens sometimes, but most family members of somebody with an eating disorder are not eating disorder professionals themselves. They've been thrown into this. They don't know this world. They're not experts in it. They have to become experts overnight. And so nurses can be allies in this by providing a lot of that psychoeducation to the families to show them how they can support their loved ones. And when we do this in collaboration with a therapist, it can open a door for a lot of growth and healing, because if things do then move towards that therapeutic realm, if we are doing it together with the therapist, then they can step in and help to guide that piece of the work also. So it can be a really, really beautiful combination work.
Mm-hmm. And I personally love having family meetings with nurses, because we have, as we put here on the side, we have this very different approach where, us therapists, we're like, okay, let's talk about that. Let's dive into that. Where nurses are, let's get things done, right? Like it's that outcome. Yeah, it's that outcome focus. And so in family work in particular, as well as team settings, which we'll talk about in a moment, that balance can really, it can really help move a client forward, and it can speak to family members who might have varying perspectives as well. They might find that one approach is speaking to them more and helping them feel empowered. So in the team setting, though, we want to highlight how important it is to have therapists, nurses, and other disciplines, right? I know we're ignoring dietitians and care partners and all the other disciplines that come together to work with our clients. But since we have therapy and nursing represented here, want to talk about how valuable it is to have both therapists and nurses present whenever possible in team meetings with clients. Again, it prevents that potential for splitting. It presents a unified front, and really often the different approaches, the talking about it versus doing it or getting things done, focusing on the outcome, that balance that nurses and therapists can provide in those meetings is often just the right mix of what the client needs. So we want to talk a little bit about how this looks in reality, right? So we have a few case presentations where we found that nursing and therapy collaborated really, really well together. So we wanted to highlight some of the specific ways in which nurses and therapists collaborated, as well as how that affected client outcomes. So the first client that we have here, client A, was in treatment with us for quite a while, about 8 months, severely undernourished at admission due to atypical anorexia, also had co-occurring disorders of major depressive disorder, recurrent, moderate, and CPTSD. Had some medical things going on. Don't have to read them all out, but a few to highlight are the dizziness, chronic pain, sleep apnea. We also were looking at sort of this client's treatment history upon coming in. They had a pretty extensive treatment history, not just for eating disorder treatment, but also for suicide attempts and suicidal ideation, self-harm, even went through, was able to address some trauma. So really with this client, going to go to the next slide here, their work in treatment focused on, of course, decreasing eating disorder behaviors. For this person, being able to decrease those behaviors while not increasing the self-harm, not using the eating disorder to soothe anxiety, and really following up with all of the medical appointments because they did have a lot going on medically. We, as a team, therapist, nurse and dietitian, all really worked to help this client utilize those DBT skills to manage the self-harm urges. And amazingly, at discharge, the client was able to abstain from self-harm for several months, which was pretty big for this person. Also was able to fully weight restore and maintain their biologically appropriate weight for 4 months prior to discharge. So didn't just hit that weight goal in discharge, like really got there and learned to tolerate and to have acceptance around what it felt like to be at their biologically appropriate weight in a healthy body. So how did this happen, right? There are a lot of different pieces that had to come together. First off, the nurse working this case was incredible in helping the client follow up on all of their medical appointments. The nurse was probably, this nurse worked her tail off. She was probably in touch with the PCP's office multiple times a week, nonetheless, with all of the other different medical providers that were involved with this client's care. This nurse also really helped the client use her sleep apnea machine for the first time in years. And this is where I think it's a great example of how we collaborated, right? Me as the therapist on this case was working more with the client on the PTSD side of things, the trauma side, just because having something covering the face brought up a lot of trauma memories and PTSD reactions. Nursing was able to help this client really understand how important using the sleep apnea machine was for her health. She was able to help reinforce those skills and really help the client come up with a nightly schedule of, okay, this is what we're going to do, practice this skill. Here's how we're going to put on the machine in such a way that feels safe to you. And really was able to reinforce what we were doing in the therapy room in a powerful way. This nurse also was able to help us focus on the therapy at different points throughout treatment by sort of taking off of my plate things that could have subsumed a lot of our time. An example of this is this client's difficulty taking medications. Often she would forget or wouldn't get them refilled. There were quite a few times throughout the day that she had to take meds and would often forget or get things mixed up. And so this is where the nurse on this case was able to sit down with this client, come up with the schedule, help her come up with, find a pill box that worked perfectly for her needs, set alarms on her phone. I mean, the whole shebang. And by the nurse spending their time working on those things, that allowed us to really focus on the deeper issues in therapy. And as a result, because the client was finally consistent with her medications, that allowed her to have some symptom relief that freed her up to actually do that work.
And I also want to add here, if the nurse had not been attuned to the way, for example, going back to the CPAP machine, that it brought up a traumatic response for this client, it could have been very abrupt. It could have been very much like, well, put it on and you need it for your health. But she was able to do it in a very different way that allowed this patient to feel safe because of how much collaboration the nurse and the therapist had together. The therapist is able to collaborate with the nurse when it came to medications and reinforce all of the ways that the structure that had been put in place to make sure that she could be compliant with the medication. And so I think that the success of it really happened because of that constant collaboration between the different team members.
Absolutely. So highlighting really quickly the outcomes of this particular case. By time of discharge, or actually I'm skipping ahead. At time of admission, we saw that this client had clinically significant elevated scores across all realms. By time of discharge, this client was at or below the clinical threshold, experiencing a reduction in eating disorder symptoms, improvement in quality of life, significant reduction in depression, which was huge for this patient, given her history, and also a reduction in anxiety, which we don't often see. A lot of times we see anxiety, and we do see this a little bit, that it gets worse, especially as we're working on the deeper issues and weight restoring, right? But so often it's difficult for it to come back down because of the distress that's being stirred up by that deeper work and the difficulty tolerating being in a healthy body. So this really highlighting these outcomes, I think, is a testament to nursing and therapy working together. And like what Chrissy said, I love the way you said that, Chrissy, being attuned to the client's needs and both coming from a compassionate client-led approach.
So here we have a different example of client B. So this is someone who came to us with a diagnosis of anorexia nervosa binge purge type, with additional diagnoses of bipolar disorder, generalized anxiety disorder, PTSD, and ADHD. She was with us for about 6 months in treatment, and while here, weight restored about 15 pounds. When she first came in, she was experiencing dizziness upon standing, intermittent hypoglycemia, acid reflux, and had a diagnosis of osteopenia. She additionally had a history of both low potassium, anemia, and she had had a heart attack. She had had 3 previous eating disorder treatment instances, and her behaviors included restricting food and fluid, excessive exercise, binging and purging, and laxative abuse. Yep. So when she was here, her work really focused on challenging eating disorder behaviors, increasing insight into her maladaptive thought patterns, emotion regulation, processing her trauma, a lot of body image work. While she was here, she was able to eliminate all of her purging behaviors, including her laxative use. She was able to use coping tools and external supports about 75% of the time. And she reported a decreased body image distress and significant decrease in trauma symptoms. And this was a case where the nurse was also very heavily involved and collaborated with both the therapist and the dietitian continuously. So for example, this was a client who was practicing regular grounding skills and distress tolerance skills. And so the nurse would actually help her practice those during their check-ins and would help her to find times throughout the day when she could actually be utilizing the skills. So often we hear clients say, I know the skills, but I don't recognize when I need to use them. And so a way that the nurse can come in is to say, well, let's practice it right now. Let's practice it when your distress level isn't at a 10 out of 10, so you can feel comfortable with it. Let's, again, coming in with those practical pieces. Let's put a timer on your phone for different times of day when you can engage in these grounding activities to really help you remember maybe when times when distress is getting higher, that these are things that you can use. The therapist and nurse also identified that she had certain triggers for behaviors. So together they reinforced the importance of her distancing herself from those physical triggers. So the bathroom with binging and purging, following meals, the bathroom was a huge trigger for her. So we made sure the nurse got in touch with people who do our scheduling for us and made sure that following any meal that she was in that was supported with us, she went straight into a session so that we made sure that that access to the bathroom wasn't as readily available. The nurse helped her to throw away the self-harm items that she had, helped her to get rid of the laxatives. And this patient was also somebody that had some pretty significant GI issues, but was always hesitant to go to a doctor due to some trauma history that she had involving doctors. So the nurse and the therapist together helped her to follow through, first on going to her PCP to get the referral that she needed, then following through with actually calling and seeing a GI specialist. She needed a lot of support and education, but just regarding the rationale and the importance of why she needed these medical tests. And the nurse was able to provide that to the client and to the therapist so that the therapist could then reinforce during all of their sessions why these were so important. The team had to be united when it came to implementing and enforcing these interventions. And overall, we saw a huge improvement in her symptoms. So if we take a look at her outcomes, we can see that when she came into treatment, she had pretty significant levels of, her EDEQ was significantly above that clinical threshold, as was her EDQOL. She had severe depression and her anxiety was also quite high. By the end of treatment, what we saw was that her EDEQ was well below that clinical threshold. Her quality of life was improving, so we did see it go below that clinical threshold. Her depressive symptoms went from severe to right on the border of that mild range. And her anxiety did decrease, though not below that clinical threshold. She was still working through a lot. And like Emma mentioned, we often see anxiety go up in that course of treatment because she had actually eliminated all of those behaviors that were such common coping tools for her. So that reduction in anxiety is actually really significant. And then we have a third case presentation. So this is client C. She came in with anorexia nervosa restricting type and unspecified anxiety disorder. And she was with us for about 8 months and had weight restoration of about 33 pounds while she was with us. When she came in, she had hypotension, hypoglycemia, hyponatremia, amenorrhea, and decreased bone mineral density. She had had no previous eating disorder treatment, and she engaged in restriction and excessive exercise. So throughout her time with us, her work focused on completing her meal plan, practicing emotion regulation, learning communication skills, building insight into what formed and maintained her eating disorder. And throughout treatment, she was able to comply with her meal plan in various settings, including she went on a vacation and was able to maintain her meal plan the entire time she was there. She had improved emotion regulation skills and developed insight into the contributing factors of her eating disorder and actually developed her own non-eating disorder voice. So this was someone who actually came to us from a higher level of care, having likely not achieved maximum benefit at that higher level of care, but stepped down. And we took her at that PHP level of care. So the nurse, to begin with, needed to provide a lot of reassurance to the team in those early days, and had a huge amount of communication with the PCP and the rest of the multidisciplinary team, especially related to things like her hypoglycemia and her hyponatremia. So the nurse was a really calming factor in the rest of the team feeling comfortable with this client being under our care, considering the level of malnutrition that she was experiencing. That communication also reassured the PCP that the client was safe remaining in our care due to those high touch points that all of the disciplines had, not just the therapist. It was that PCP knew that it was the therapist, the nurse, the dietitian, the psychiatric provider, the care partner, all of them seeing that client on such a regular basis. The nurse was also really instrumental in this case when it came to family coaching. So at the beginning, the family needed a lot of reassurance regarding medical concerns, but this nurse also did one-to-one coaching with the family the entire time the family was here, related to validation. There was a large component of diet culture in the household that was a contributing factor to the eating disorder. And so with the coaching, the nurse was really able to help this family overcome some of that. And their relationship with the client improved tremendously while she was with us. The therapist in this case was also able to focus on family therapy while the nurse was focusing on just the parents, and so the nurse was giving very direct feedback to these parents, which they were then able to change that mode of communication that they had in the family sessions to really help with the overall outcome. So when she discharged from us, she had achieved over 90% of her weight goal. She was thriving. She was returning to school. She had no abnormal lab values or vitals. And prior to discharge, she actually resumed her menstruation. So as you can see here in her outcome measures, by the time she discharged from us, she showed almost no signs of eating disorder behaviors according to her EDEQ. Her EDQOL showed that the eating disorder was no longer affecting her quality of life. Her depression score, which had been moderately severe in the moderately severe range, was now in the none to minimal range, and her anxiety was well below that clinical threshold.
Amazing. So I feel like we could keep talking about case presentations, but really just want to spend the next few minutes highlighting overall the amazing involvement of nurses and how that can improve client outcomes. So often nurses are really an underutilized resource, especially in higher levels of care and eating disorder treatment. And so we just wanted to spend a few moments highlighting the incredible feedback that our clients give about nurses and their heavy involvement in their care. And shout out in particular to Within Health nurses. You guys are incredible. Really and truly, it's not just the clients that are raving, it's us too. Being able to collaborate and to really have, again, not just that typical, okay, talking about medications and vitals and labs, but really looking at the whole person and reinforcing what's happening in the therapy room, and therapists being able to know what's happening on the medical side so we can reinforce that as well. Really, we believe helps improve client outcomes greatly. So we don't have to read all of these, but you can read them as we're talking, just the impact that nursing can have. And again, this isn't just nurses. This is, again, the collaboration of all of the different disciplines, but particularly of nursing, being able to come together and give clients that compassionate, attuned care. Chrissy, is there anything you want to say here before we move on?
Just a big shout out to all my Within Health nurses that I know are on this presentation right now. We love you.
All right.
So for kind of practical tips and application, to the nurses who are here, don't be afraid to play a bigger role in a client's treatment. Yes, you are going to pass things over to your therapist when it's needed, but you have a wealth of knowledge and we want you to use it. Use appointment time to support clients in meeting relevant therapeutic goals. So you can do things with them like diaphragmatic breathing. You can help them to figure out which DBT distress tolerance skills work the best for them and help them practice those. Help those clients connect the dots between the medical and therapeutic goals. So how medical stability actually supports these therapeutic goals. Until they're medically stable, they're not going to be able to fully recover, their brain isn't going to be working at 100% until they really get to those goals medically that they need to.
Mm-hmm. And therapists, similarly, we want to refer to nursing when needed, right? There are times where we do need to punt, or when we need to send that message in the middle of session with the client's permission to the client's nurse, hey, there's some things that, I want to put on your radar. And we need to not be afraid to reinforce medical goals with clients, to actually provide that psychoeducation that reinforces what our nurses are sharing in their sessions, and to reinforce the importance of medical recommendations. And from a therapeutic side, see what the barriers are. We want to use session times to help clients even meet some of their medical goals, if helpful and necessary. So with clients who have difficulty hydrating, make a point in session. Yeah, drink water. I'm going to drink some with you, right? Like, at the beginning and at the end, or, whatever you guys decide, get creative, know what a client's medical goals are, and don't be afraid to follow up in helping a client actually achieve them. And for both nurses and therapists, we want to really encourage everyone to be cognizant of coming together as a team for case conceptualization. I think, speaking as a therapist, it's often really easy for therapists to have the case conceptualization, and often we're the ones presenting that in meetings, and we're the ones doing the treatment plan. And yes, those are things that therapists often do take the lead on at higher levels of care. And that doesn't mean that other disciplines don't weigh in on case conceptualization. It means that all disciplines need to weigh in on treatment trajectory. We need to be having frequent and open all-team conversations about appropriate level of care. We need to really structure our team meetings in such a way that we're supporting all disciplines having an equal voice. I want to recognize something that I forgot to mention with client A was the support of nutrition. And I know dietitians, you're not getting as much of a shout out here, because like I said, Chrissy and I are a little biased being nurses and therapists, but dietitians are incredibly, yes, yeah, this is the new feature, love it. Incredibly important in our clients' care, and we want to support all disciplines having an equal voice. So if that means structuring team meetings in such a way that maybe we're actually changing up the order of who's presenting first based on which discipline is taking precedence at which time. This client has a lot going on medically. Let's go ahead and have nursing present. This client is struggling nutritionally, and most of our therapeutic and nursing sessions are focusing on the nutrition piece and reinforcing that. Let's have dietitians share first, right? Like really supporting that collaborative, multidisciplinary approach, even in just small things like the way we structure our meetings. And remembering that any team member, including nurses, can call a team meeting. We all have equal and important things to share about what we're seeing. And we want to empower everyone to sometimes step forward into the driver's seat when needed, and empowering other disciplines to take a step back when needed as well, and to reinforce and back each other up. So we've come to the end of our time. Thank you all so much. I know this was, again, a little bit more of a conversation, us sharing our personal experiences, a little bit more of what we do at Within Health, but hope that you have a few practical tips and tricks to walk away with to improve your multidisciplinary treatment approach, and to really help our clients heal as whole people.
Thank you so much, everyone.
Thank you, Chrissy and Emma. That was so insightful. I hope you're checking out the chat. You're getting a lot of love in the chat. So make sure you absorb all of that, because you both deserve it. I just want to thank everybody for attending the session today and for having this space with us. Thank you again, Emma and Chrissy, for sharing. If you haven't already, we also have some more summit events that'll be later today and this afternoon. Feel free to check those out as we wrap things up for our summit this year. But again, thank you all for joining us, and thank you to Chrissy and Emma.